Broadcasting from the Temple of Zoom, it's the Jen and Nathan Show. Today's special episode is all about elbow dislocation. So without further ado, take it away, Jen.
All right, so we are going through elbow dislocation. And first, we're going to start with the learning objectives for this unit. There are only two. The first one is, what is the most common direction for an elbow dislocation? And describe the bony positions of a posterior dislocation. And then the second one is, describe the management of an elbow dislocation. All right, so first, mechanism of injury. So this happens when the bones of the elbow joint are forced out of alignment, usually by falling on an extended outreached hand. It can be isolated, so it can be just the dislocation, or it can be accompanied by a fracture. Stay tuned for the most popular fracture. It can be simple or complex, so that's whether it's isolated or accompanied by the fracture. So simple is isolated, and complex is it's accompanied by the fracture. It is the second most frequently dislocated joint, aside from the shoulder. It occurs most often in men, and 60% of these injuries are on the non-dominant arm, thankfully. All right, so anterior versus posterior. So a posterior injury, posterior dislocation is going to be the most common, and that is when you're falling on an outstretched arm. And what happens is the radius and the ulna are driven posteriorly to the humerus. And so you have the olecranon process that moves up into the, let's see, here we go. Hopefully you guys can see my mouse here. So the olecranon process moves up into the olecranon fossa further up, and which places the trochlea anterior to the coronoid process here. So yeah, and then the anterior, which is least common, only in 1 to 2% of injuries, it occurs with the posterior forces to the elbow when flexed at 90 degrees. So that's when you're like landing on your elbow with it bent. This is the most painful injury and also the most dangerous. All right, and take it away, Nathan.
All right, so treatment for isolated posterior dislocation. And so this is without a fracture involved. In the acute stage, lasts approximately 3 weeks. First step is going to be to close reduction, get that joint back in the right place. And then there'll be immobilization in a sling for approximately 3 weeks with elbow flexion at 90 degrees. We're going to be using modalities for pain and inflammation during that time. And hand and shoulder and wrist active range of motion is, if allowed by the PT or the physician, is encouraged as long as you're not putting stress on the elbow. And we'll be doing a conditioning program for the contralateral arm and for overall health, things like cardio. We'll want to do some gentle active range of motion of the elbow joint after 3 days. And there is some argument about that. Some people say 3 days, some people say wait longer, which Jill will also talk about in one of her lectures as well. And then we're going to stick to flexion and extension in a pain-free range for that active range of motion. And very important note here, we're going to do no passive range of motion or stretching during the acute phase due to the risk of myositis ossificans. And then moving into the subacute stage, it's about 3 weeks to 8 weeks. The progression in this stage is really dictated by the joint and ligament healing. There is a lot of damage to soft tissue, joint capsule, joints, ligaments, and muscles. And so as that healing progresses, that's kind of what dictates our progress here. I'm going to continue with active range of motion. We're going to do submaximal multi-angle isometrics. Again, as the healing progresses, we're going to add in resistance exercises and eccentric and concentric exercise for the biceps to control the hyperextension forces, because we really don't want hyperextension to occur. And so we're going to proceed cautiously with all of our extension because that was the method of injury and we want to avoid re-injury. And then in our return to sport or return to function, that's going to be 2 months and on. And like we've seen with most of these others, we're going to be doing progressive functional exercises using bands, weights, open or closed kinetic chain, and we could do stretching, but we still don't want to do overstretching even in this phase. And then we'll talk a little bit about dislocation with fracture. So the radial head fracture is the most common associated with elbow dislocation. And for that, they do radial head excision. That's the most common surgical procedure to treat that. And when we're dealing with the treatment protocol here, we're going to be, it's pretty similar to the non-fracture, but the protocol for the fracture involved dictates the overall treatment. And Jill talks more about radial head excision and radial head fractures in her lecture. And I'm sure you've all already listened to that one. And then you can also have posterior dislocation, a radial head fracture, and a coronoid fracture together, known as the terrible triad. And I'm going to leave this question open. Can you name another terrible triad we learned about? I'm sure you all can. And then, of course, we got some complications and special considerations to talk about. Complications, we have the possibility of neurovascular injuries. We got the ulnar nerve, medial nerve, and radial nerve, and then the brachial artery. Myositis ossificans is a big one that we talk a lot about, and we had a lecture about. And then it's also common to lose full extension with elbow dislocations. You'll have like a 10-degree loss after 2 years is pretty common. And we should be making all efforts to gain full extension, but the 10-degree loss is not functionally limiting for most people. And special considerations, I mentioned a couple of these already, but they're worth having their own slide for. So no forceful extension of the elbow until 8 weeks out. And again, that's usually because it's a hyperextension injury in most cases, and we don't want to risk re-injury. And again, no passive range of motion or stretching in the acute phase due to the risk of myositis ossificans. And then we talked a little bit about the amount of extensive soft tissue healing that's going on in the joint capsule, the muscles, the tendons, and the ligaments. And it really requires 8 to 10 weeks for full stability and function to return to a satisfactory state. And then with the radial head excision, if you keep the patient immobilized longer than 4 weeks, you will lose 25 to 30 degrees of pronation and supination. So keep that in mind. And there are our sources. Otherwise, that's all we have for you guys. Thanks for listening.